The client is brought to the emergency department after falling off a roof and landing on his back. AT1 spinal fracture is diagnosed. The client's blood pressure is 74/40ths of a millimeter Hg, pulse is 50 per minute, and skin is pink and dry. What nursing action is a priority? 1. Administer IV normal saline. 2. Determine if urinary occult blood is present. 3. Perform a neurological assessment. 4. Verify that there is no stool impaction. Correct answer. Explanation. This presentation is classic for neurogenic shock, a distributive shock. Vascular dilation with decreased venous return to the heart is present due to loss of innervation from the spine. Classic signs, symptoms are hypotension, bradycardia, and pink and dry skin from the vasodilation. Neurogenic shock usually occurs in cervical or high thoracic injuries, T6 or higher. Systolic blood pressure should remain at 80 mm Hg or above to adequately perfuse the kidneys. Administration of fluids is a priority to ensure adequate kidney and other organ perfusion. Option 2. Testing for the presence of blood in the urine is important in determining if kidney damage has occurred, but circulation stability is a priority. Option 3. A neurological assessment is essential, but circulation stability is a priority. C before D. Disability. Option 4. Bladder and stool impaction are etiologies for autonomic dysreflexia and generally occur in a client with a high-level fracture at T6 or above with a stimulation below the fracture. Autonomic dysreflexia is a medical emergency that presents with severe headache, hypertension, piloerection, and diaphoresis. It is seen weeks to years after the injury. Educational objective. Neurogenic shock, distributive shock can occur from vasodilation soon after spinal injury. Classic symptoms are hypotension, bradycardia, and pink and dry skin. The hypotension must be treated with isotonic fluids to maintain vital organ perfusion. An emergency department nurse is sent to the scene of a massive motor vehicle collision. A client there reports neck pain. Which actions should the nurse perform at this time? Select all that apply. 1. Apply a hard cervical collar. 2. Assess neck range of motion. 3. Inspect client's respiratory pattern. 4. Position client flat on firm surface. 5. Use log rolling technique if moving client. Correct answer. The initial priorities for a client with a suspected cervical spine injury are to ensure a patent airway and immobilize the spine to prevent further injury. This includes applying a rigid hard collar, placing the client on a firm surface, e.g., a backboard, and moving the client as a unit, log rolling, if required. Options 1, 4, and 5. A soft foam cervical collar does not provide immobilization. Further stabilization is achieved by taping down the client's head and using straps to immobilize the arms, especially if the client is not cooperating. After immobilizing the client, the nurse should obtain a baseline set of vital signs to monitor for neurogenic shock, e.g., hypotension, bradycardia, poikilothermia, i.e., inability to regulate body temperature. A potential complication of spinal cord injury. The nurse should also assess the client's respiratory rate, pattern, and effort. Presence of abdominal breathing or increased work of breathing may indicate impending loss of airway and require prompt rapid sequence intubation. Option 3. Option 2. Movement of the neck, upper extremities should be avoided until cervical spine injury is ruled out with imaging, which is done after the spine is immobilized with a hard collar. Educational objective. The priorities for a client with a suspected cervical spine injury are maintaining a patent airway and spinal immobilization. Interventions include application of a rigid hard collar, placing the client on a firm surface, log rolling the client during movement and transfers, and continued assessment of need for an advanced airway. Which would be the appropriate client criteria for activating a rapid response team at the hospital? Select all that apply. VCS, score of 9 throughout shift. 2. Heart rate remaining at 58 beats per minute for more than 1 hour. 3. Postoperative pain rated at 10. 4. Respiratory rate maintaining an increase to 30 breaths per minute. 5. Sustained change in level of consciousness for 10 minutes. Correct answer. The Rapid Response Team is activated to marshal additional experienced and specialized resources for an acute need to try to prevent a client from deterioration into a code arrest situation. The team has critical care expertise to provide immediate attention to unstable clients in non-critical care units and usually consists of a respiratory therapist, a critical care nurse, and a physician or advanced practice registered nurse. Recommended criteria to consider according to the Institute for Healthcare Improvement include the following. An acute change in any of the following: heart rate less than 40 or greater than 130 per minute. Systolic blood pressure less than 90 mm Hg. Respiratory rate less than 8 or greater than 28 per minute. Option 4. Oxygen saturation less than 90 despite oxygen. Urine output less than 50 milliliters per hour. Level of consciousness. Option 5. Option 1. The GCS is abnormal but is stable in the abnormality. A rapid response would be used for a significant deteriorating trend. Option 2. Many clients routinely run a slowed pulse rate, athletes. There is no indication that this is a new change for the client. It would be concerning if there was an effect on perfusion, accompanied by chest pain, or if the heart rate was less than 40 per minute. Option 3. Unrelieved pain is concerning, but the nurse can handle this through assessing the etiology, calling the healthcare provider, or adjusting the analgesia. Pain in and of itself is not an indication of client instability. Educational objective. Rapid response criteria for unstable clients in a non-acute care setting usually includes sudden, significant changes that do not respond to treatment. When caring for a client with a left radial artery catheter, which assessment data obtained by the nurse indicates the need to take immediate action. 1. Capillary refill of less than 3 seconds. 2. Left hand cooler than right. 3. Mean arterial pressure of 65 mm Hg. 4. Pressure bag at 300 mm Hg. Correct answer. Although the Allen's test is performed before cannulating the radial artery and determines the adequacy of ulnar artery blood flow, circulation to the extremity is monitored frequently. The nurse must assess color, capillary refill, sensation, temperature, and movement per institution policy. Impairment in any of these parameters must be reported immediately because it may indicate impaired circulation to the extremity, and removal of the catheter may be necessary. Option 1. Capillary refill of less than 3 seconds is an indicator of normal arterial circulation. Option 3. A mean arterial pressure of 65 mm Hg is adequate to perfuse the vital organs. Option 4. To maintain patency of the arterial blood pressure monitoring system, an intravenous bag of normal saline solution is placed in a pressure infuser device. The device is set to maintain continual pressure at 300 mm Hg. The pressure drops as the volume of solution in the bag decreases and can be pumped back up. This does not pose an immediate threat to the client. Educational objective. When caring for a client with a radial, brachial, or femoral arterial line in place, the nurse must be able to assess for complications. These include hemorrhage, infection, thrombus formation, and circulatory and neurovascular impairment. A nurse in the emergency department is caring for a homeless client just brought in with frostbite to the fingers and toes. The client is experiencing numbness and assessment shows mottled skin. Which interventions should be included in the client's plan of care? Select all that apply. 1. Apply occlusive dressings after rewarming. 2. Elevate affected extremities after rewarming. 3. Massage the areas to increase circulation. 4. Provide adequate analgesia. 5. Provide continuous warm water soaks. Correct answer. Explanation: frostbite involves tissue freezing, resulting in ice crystal formation in intracellular spaces that causes peripheral vasoconstriction, reduced blood flow, vascular stasis, and cell damage. Superficial frostbite can manifest as mottled, blue, or waxy yellow skin. Deeper frostbite may cause skin to appear white and hard and unable to sense touch. This can eventually progress to gangrene. Treatment of frostbite should include the following: remove clothing and jewelry to prevent constriction. Do not massage, rub, or squeeze the area involved. Injured tissue is easily damaged. Option 3. Immerse the affected area in water heated to 98.6 to 102.2 F, 37 to 39 C, preferably in a whirlpool. Higher temperatures do not significantly decrease rewarming time but can intensify pain. Option 5. Avoid heavy blankets or clothing to prevent tissue sloughing. Provide analgesia as the rewarming procedure is extremely painful. Option 4. As thawing occurs, the injured area will become edematous and may blister. Elevate the injured area after rewarming to reduce edema. Option 2. Keep wounds open immediately after a water bath or whirlpool treatment and allow them to dry before applying loose, non-adherent, sterile dressings. Option 1. Monitor for signs of compartment syndrome. Educational objective: care of the client with frostbite focuses on preventing further injury and reducing pain. This includes removing items that can cause constriction or sloughing, no massaging or rubbing of the injured area, providing warm water soaks and analgesia, elevating injured areas, applying loose non-adherent, sterile dressings, and monitoring for compartment syndrome. The nurse cares for an intubated client on mechanical ventilation with worsening cerebral edema from increased intracranial pressure (ICP). Which nursing interventions help reduce ICP? Select all that apply. 1. Clustering as many interventions as possible when providing care. 2. Hyperventilating before suctioning. 3. Maintaining a quiet, dark environment. 4. Maintaining the head in a neutral midline position. 5. Suctioning for 30 seconds to remove endotracheal tube secretions at regular intervals. Correct answer. Explanation: most nursing activities increase intracranial pressure (IC) in brain injuries. The goal is to reduce ICP while managing basic client needs. During interventions, ICP should not exceed 25 mm Hg and should return to baseline within a few minutes. Metabolic demands, e.g., pain, straining, agitation, shivering, fever, hypoxia, increase brain blood supply and raise ICP. Nursing interventions to control ICP include elevating the head of the bed to 30 degrees with the head neck in a neutral position to reduce venous congestion. Option 4. Administering stool softeners to reduce the risk of straining, e.g., Valsalva maneuver, managing pain well while monitoring sedation, managing fever, e.g., cool sponges, ice, antipyretics, while preventing shivering. Maintaining a calm environment with minimal noise, e.g., alarms, television, hall noise. Option 3. Ensuring adequate oxygenation, hyperventilating and pre-oxygenating the client before suctioning. Reducing CO2, a potent cerebral vasodilator, by hyperventilation induces vasoconstriction and reduces ICP. Option 2. Option 1. Stimulation increases oxygen metabolism within the brain, increasing the risk for irreversible brain damage and increased ICP. Limit performing interventions unless absolutely necessary and avoid performing interventions in clusters. Option 5. The nurse should suction a maximum of 10 seconds and only as necessary to remove secretions. Prolonged suctioning increases ICP. Educational objective: nursing activities can increase intracranial pressure, IC, and should be limited and spread throughout the day. The goal is to reduce ICP while managing basic needs. Nurse caring for an 11-month-old child in the pediatric hospital. Which of these child's findings would be a common criterion to activate the rapid response team? Select all that apply. 1. New onset right-sided paralysis of extremities. 2. Pulse rate sustained at 120 per minute. 3. Respirations continued at 38 per minute. 4. Sudden inability to be aroused to an awake state. 5. Temperature of 101.3 F, 38.5 C. Correct answer. Rapid response teams are formed as a means to get critical care specialists to the bedside of clients who are not in a critical care unit when acute, significant changes occur in their condition. Each institution sets its own criteria, but it usually includes acute changes in heart rate, systolic blood pressure, respiratory rate, oxygen saturation, level of consciousness, and/or urine output. Although strokes occur more commonly in adults, they can occur in children. Symptoms found in both groups can be similar, such as unilateral paralysis, which is usually found with vessel abnormalities or a hematologic complication, e.g., sickle cell, cancer. Option 1. Just as in adults, emergency treatment for children should be activated. A sudden loss of consciousness is emergent in any client. Option 4. Option 2. Normal heart rate for an infant, 1 to 12 months, is 100 to 160 per minute. Option 3. Normal respiration rate for an infant, 1 to 12 months, is 30 to 60 per minute. Option 5. A fever is ordinarily not an emergency situation that meets the criteria to activate the rapid response team. It can signal a serious condition in infants who are age less than 1 month or in children age less than 2 years who have a temperature greater than 104 F, 40 C, without a localized source, due to an immature immune system. However, in this case, it would probably be more effective to call a healthcare provider to prescribe appropriate diagnostic tests, e.g., complete blood count, cultures, and treatment, e.g., antibiotics. A fever does not usually require immediate life-saving intervention. Educational objective. Rapid response teams are formed as a means to get critical care assistance to the bedside of clients, not in intensive care, with acute significant changes in their condition. Common criteria include sudden, significant changes in pulse rate, respiration rate, systolic blood pressure, oxygen saturation, level of consciousness, and/or urine output. The emergency department nurse is caring for a client who requires gastric lavage for a drug overdose. Which action would be appropriate? 1. Lavage through a small bore nasogastric tube. 2. Place client in Trendelenburg position during lavage. 3. Prepare intubation and suction supplies at the bedside. 4. Wait an hour after gastric decompression to initiate lavage. Correct answer. Gastric lavage, GL, is performed through an orogastric tube to remove ingested toxins and irrigate the stomach. GL is rarely performed as it is associated with a high risk of complications, e.g., aspiration, esophageal or gastric perforation, dysrhythmias. GL is only indicated if the overdose is potentially lethal and if GL can be initiated within 1 hour of the overdose. Activated charcoal administration is the standard treatment for overdose, but it is ineffective for some drugs, e.g., lithium, iron, alcohol. Intubation and suction supplies should always be available at the bedside during GL in case the client develops aspiration or respiratory distress. Option 3. Option 1. GL is usually performed through a large bore, 36 to 42 French, orogastric tube so that a large volume of water or saline can be instilled in and out of the tube. Option 2. During GL, clients should be placed on their side or with the head of bed elevated to minimize aspiration risk. Option 4. GL should be initiated within 1 hour of overdose ingestion to be effective. The client's stomach should be decompressed first, but lavage should be initiated as soon as possible afterwards. Educational objective. Gastric lavage is used to remove ingested toxins and irrigate the stomach after a drug overdose. It should be initiated within 1 hour of overdose. The nurse should position the client to prevent aspiration and have emergency respiratory equipment at the bedside. The charge nurse is evaluating the skills of graduate nurses, GN, who are caring for clients with shock. Which action taken by a GN indicates a need for further education? 1. Administers furosemide to a client with elevated pulmonary artery wedge pressure in cardiogenic shock. 2. Applies an SpO2 sensor to the forehead of a client with septic shock rather than using a finger. 3. Raises the head of the bed to high Fowler position for a client with hypovolemic shock. 4. Titrates norepinephrine infusion to maintain mean arterial pressure 265 mm Hg in a client with anaphylactic shock. Correct answer. Hypovolemic shock occurs when there is inadequate circulating volume to maintain perfusion due to hemorrhage, decreased fluid intake, or fluid loss, e.g., vomiting, diarrhea, diuresis. Care of the client with shock includes restoring circulation, e.g., IV fluids. Positioning for a client with hypovolemic shock involves elevating the legs and maintaining the head of bed, HOB, is less than or equal to 30 degrees. This allows gravity to assist with venous return, cardiac output, and perfusion of vital organs, e.g., brain, kidney. Raising the HOB greater than 30 degrees, e.g., high Fowler position, seated upright, is inappropriate in a client with hypovolemic shock and inadequate circulating vascular volume. Option 3. Option 1. Elevated pulmonary artery wedge pressure, normal, 6 to 12 mm Hg, is a manifestation of cardiogenic shock. Diuretics, e.g., furosemide, are appropriate for cardiogenic shock because decreasing left ventricular preload reduces cardiac workload. Option 2. Placing the SpO2 sensor on the forehead rather than the finger can provide more accurate readings in clients with decreased peripheral tissue perfusion, e.g., shock, vasopressor therapy. Option 4. Norepinephrine is a vasopressor used to increase stroke volume, cardiac output, and mean arterial pressure, MAP. Norepinephrine should be titrated to maintain MAP 265 mm Hg for a client in shock, e.g., anaphylactic. Educational objective. Positioning for a client with hypovolemic shock involves elevating the legs and maintaining the head of bed as less than or equal to 30 degrees to allow gravity to assist with venous return and increase cardiac output and perfusion. The nurse is caring for a client who is 1 day postoperative extensive abdominal surgery for ovarian cancer. The client is receiving IV Ringer's lactate at 100 ml per hour in continual epidural morphine for pain control. The Foley catheter urine output has decreased to less than 20 ml per hour over the past 2 hours. The postoperative hematocrit is 36%, 0.36, and the hemoglobin is 12 grams per deciliter, 120 grams per liter. Which action should the nurse carry out first? 1. Assess vital signs. 2. Increase the IV rate to 125 ml per hour. 3. Notify the healthcare provider. 4. Perform a bladder scan. Correct answer. Third spacing of fluids can occur 24 to 72 hours after extensive abdominal surgery as a result of increased capillary permeability due to tissue trauma. It occurs when too much fluid moves from the intravascular into the interstitial or third space, a place between cells where fluid does not normally collect, i.e., injured site, peritoneal cavity. This fluid serves no physiologic purpose, cannot be measured, and leads to decreased circulating volume, hypovolemia, and cardiac output. The priority intervention is to assess vital signs as the manifestations associated with third spacing include weight gain, decreased urinary output, and signs of hypovolemia, such as tachycardia and hypotension. If third spacing is not recognized and corrected early on, postoperative hypotension can lead to decreased renal perfusion, prerenal failure, and hypovolemic shock. Option 1. Option 2. increasing the IV flow rate of the isotonic solution may be an appropriate intervention once the nurse has assessed the client, including taking a full set of vital signs. The nurse should intervene only after assessing to rule out other problems for which an increase in IV fluid intake would not be an appropriate solution, e.g., Foley catheter obstruction. Option 3. The nurse will notify the healthcare provider to report oliguria, less than 0.5 milliliters per kilogram per hour, after collecting all of the data necessary, i.e., vital signs. This is not the nurse's first action. Option 4. Urinary retention is possible following surgery due to the adverse effects of anesthesia, opioids, anticholinergic drugs, and immobility. However, a bladder scan is not an appropriate action in this situation as the client has a Foley catheter. Irrigating the catheter is the appropriate intervention if the nurse questions its patency. Educational objective. Third spacing can occur following extensive abdominal surgery and can lead to hypovolemia, decreased cardiac output, hypotension and tachycardia, and decreased urine output. Monitoring vital signs and urine output and maintaining IV fluids are appropriate interventions to prevent prerenal failure and hypovolemic shock. The nurse is caring for a client with sepsis and acute respiratory failure who was intubated and prescribed mechanical ventilation 3 days ago. The nurse assesses for which adverse effect associated with the administration of positive pressure ventilation, PPV. 1. Dehydration. 2. Hypokalemia. 3. Hypotension. 4. Increased cardiac output. Correct answer. Positive pressure ventilation, PP, delivers positive pressure to the lungs using a mechanical ventilator, MV. Either invasively through a tracheostomy or endotracheal tube or non-invasively through a nasal mask, face mask, nasal prongs, or a mouthpiece. The most common type used in the acute care setting for clients with acute respiratory failure is the volume-cycled positive pressure MV, which delivers a preset volume and concentration of oxygen, e.g., 21% to 100% with varying pressure. Positive pressure applied to the lungs compresses the thoracic vessels and increases intrathoracic pressure during inspiration. This leads to reduced venous return, ventricular preload, and cardiac output, which results in hypotension. The hypotensive effect of PP is even greater in the presence of hypovolemia, e.g., hemorrhage, hypovolemic shock, and decreased venous tone, e.g., septic shock, neurogenic shock. Option 1. Fluid and/or sodium retention usually occurs about 48 to 72 hours after initiation of PP due to 1. Increased intrathoracic pressure and decreased cardiac output that stimulate the kidneys to release renin. 2. Physiologic stress that leads to the release of antidiuretic hormone and cortisol. And 3. Breathing through the ventilator's closed circuitry, which decreases insensible loss associated with respiration. Option 2. Hypokalemia is not associated with PPV. Option 4. PP increases intrathoracic pressure and reduces venous return to the right side of the heart, reducing preload and cardiac output as well. Educational objective. Positive pressure ventilation causes increased intrathoracic pressure and reduced venous return and cardiac output, which can result in hypotension. The emergency department nurse receives a client with extensive injuries to the head and upper back. The nurse will perform what action to allow the best visualization of the airway? 1. Head tilt chin lift in the supine position on a backboard. 2. Head tilt chin lift in the Trendelenburg position. 3. Jaw thrust maneuver in semi-Fowler's position. 4. Jaw thrust maneuver in the supine position on a backboard. Correct answer. Clinical situations involving trauma should follow ABC: airway, breathing, and circulation. Airway assessment is particularly critical in clients with injuries to the head, neck, and upper back. Injury to the upper back should be treated as spinal trauma until the client has been cleared by an advanced trauma life support qualified healthcare provider. Nurse is evaluating the skills of graduate nurses, GN, who are caring for clients with shock. Which action taken by a GN indicates a need for further education? 1. Administers furosemide to a client with elevated pulmonary artery wedge pressure and cardiogenic shock. 2. Applies an SpO2 sensor to the forehead of a client with septic shock rather than using a finger. 3. Raises the head of the bed to high Fowler position for a client with hypovolemic shock. 4. Titrates norepinephrine infusion to maintain mean arterial pressure 265 mm Hg in a client with anaphylactic shock. Correct answer. Hypovolemic shock occurs when there is inadequate circulating volume to maintain perfusion due to hemorrhage, decreased fluid intake, or fluid loss, e.g., vomiting, diarrhea, diuresis. Care of the client with shock includes restoring circulation, e.g., IV fluids. Positioning for a client with hypovolemic shock involves elevating the legs and maintaining the head of bed, HOB, is less than or equal to 30 degrees. This allows gravity to assist with venous return, cardiac output, and perfusion of vital organs, e.g., brain, kidney. Raising the HOB greater than 30 degrees, e.g., high Fowler position, seated upright, is inappropriate in a client with hypovolemic shock and inadequate circulating vascular volume. Option 3. Option 1. Elevated pulmonary artery wedge pressure, normal, 6 to 12 mm Hg, is a manifestation of cardiogenic shock. Diuretics, e.g., furosemide, are appropriate for cardiogenic shock because decreasing left ventricular preload reduces cardiac workload. Option 2. Placing the SpO2 sensor on the forehead rather than the finger can provide more accurate readings in clients with decreased peripheral tissue perfusion, e.g., shock, vasopressor therapy. Option 4. Norepinephrine is a vasopressor used to increase stroke volume, cardiac output, and mean arterial pressure, MAP. Norepinephrine should be titrated to maintain MAP 265 mm Hg for a client in shock, e.g., anaphylactic. Educational objective. Positioning for a client with hypovolemic shock involves elevating the legs and maintaining the head of bed as less than or equal to 30 degrees to allow gravity to assist with venous return and increase cardiac output and perfusion.